So we're going to talk a little bit, we're going to go, as I say, a little bit back up, higher level, to look at possible changes, because nothing's set in concrete at the moment, but making you aware of what may change in the way that we assess risk, which is going to change down at the grassroots level of how we actually talk to our patients. So currently at the moment, the whole point of risk assessment is to figure out who's next. So who out of our population is at the most risk and is going to benefit the most from any intervention I might have, okay? And at the moment we use a calculator in New Zealand that takes a collection of risk factors and gives you a number, which is an estimate of a 5-year risk of someone having a heart attack or a stroke. That's the basic premise, keep it down to. And our current cohort is based on 5,000 North Americans living in the top right-hand corner of America, okay? There's no Maori up there. There's no Pacific Islanders. There's no nothing we've had. And our current calculator is about 15 years old, so it was generated about that time and modified for New Zealand, okay? So we've now taken that, and it's possible that we're going to make a New Zealand-made one. So Rod Jackson and his team at Auckland University have created a cohort of New Zealanders and have followed them for a length of time. And from that collection of New Zealanders, we can generate our own, if you like, risk equations, okay? It sounds very sensible, sounds all well and good up to that point, and we all agree that sounds better. It's better to have 200,000 New Zealanders forming our cohort than 5,000 Yanks, all right? There's probably no argument at that point. However, so if you have a risk calculator and I collect a bunch of people and I measure some risk factors and I want to estimate what their chance of having a heart attack is, if my calculator is perfect, it follows this line, okay? So 10% of the people that I think have got a 10% risk are going to go on and have a heart attack. 15% of the people that I calculate at 15% are going to go on and have, right? So it's fairly simple. So that would be the perfect world. And when Rod and his team created the one we're using at the moment back in the early 2000s, that's exactly what it looked like. It was a fairly good line and it was fairly accurate. But over time, I'm afraid, it has drifted off, probably because we're doing a better job. Okay, our lifestyles are better, smoking rates have come down, our treatment's better, so on and so forth. So your chance now of having a heart attack with the same collection of risk factors is actually lower, okay? So right now, was techno, right. I thought there was a light there, but there probably isn't. So right now, if you went to your practice last week and had a risk assessment, top one, thanks. So if you went, tiny red. So for those of you who've got the colour blindness, this is a completely pointless exercise. so I won't bother. So right now, if I went, so if I do a risk assessment at the moment with a patient of mine on yesterday, and the number that comes out of the calculator says it's 17%. In reality, okay, that risk is more like 10%. Okay, so suddenly we have been overestimating for people at the higher risk. Hasn't just happened, it's been gradually changing over the years, okay? So every year it's probably drifted, and so finally we're figuring it out now. If you're lower risk, you can see from the graph that it hasn't changed dramatically, but higher risk, it's quite far off. The new one that Rod and his team have created from the predict cohort, as you can see, follows the line again. So everything will be fine, but you'll notice, or I'll show you, that we don't go anywhere near as high as we were on that last one. We're up to 20 here. The new one shows we're not getting out there. So everybody's risk has come down, okay? But this is not a time to jump on an aircraft carrier and say, great, mission accomplished, we've fixed it. The country is saved. I can get my gold medal and go back to windsurfing and not have to do my job anymore. That's not quite what this means. What it has meant is that if I looked at the distribution, I can hear the snoring already, but just bear with me. If the distribution of risk over the country is currently like that in the red line, then it will become more like the blue. Don't worry too much about the numbers because this is just my illustration of what's going to happen. But we're going to have more people at what we would currently call kind of low to moderate risk, okay? Now, one key point, okay, if I lined everybody up in New Zealand in a big line from the next person to have a heart attack all the way down to the end of the line to the person who's never going to have a heart attack, the order of that line is not going to change with a new calculator. If you're the most risky today, you'll be the most risky with the new calculator, okay? But the number that my calculator generates is different. And so if we're using that number as a way to start a conversation with a patient about their risk, and since that's what this is all about, it's not about just doing the calculation, filing it in their notes and sending them off home, patting myself on the back. It's about having a conversation with my patient about that risk so that he or she understands what that means in their own context. Do they want to do anything about their risk? Since it's their risk, it's not my risk, okay? So, but if I'm using the number, so if I'm using the 17% as a tool to try and encourage behaviour change, and now I find that the number is actually 11, 11's not as impressive as 17. So we suddenly have to think a little bit about how we're discussing risk. Okay, it makes our conversations slightly more tricky. So just to make the point that, again, a mission is not accomplished, okay, because still every 90 minutes a New Zealander is dying of heart disease, okay? There's still loads of people having strokes across the country, many of which we could do something about. No, I'm not suggesting that all 99-year-olds we should stop all heart attacks at 99. If they want to have a heart attack at 99, good on them for getting to 99 to have a heart attack. But there are certainly people today having heart attacks, and we've met one of them at a young age who we should be able to do something about them, okay? And just to illustrate that even further, if you look at the OECD numbers, you know, we're amongst the powerhouses of world health of Mexico. We're not amongst where we probably should be with Australia and the United Kingdom. We're higher. And although we are getting better, so although that's the graph on the right shows the improvement, so the higher the blue chart towards me, the better we're doing, other countries are doing better than us, faster than us. So mission is not accomplished. But with the new calculator comes a bit of a change to how we discuss things. And particularly think about equity, I think it's going to make our life a bit trickier because I think it makes it more difficult, okay? Because you've already got something that people are avoiding talking about. So we're already having trouble getting them to come into the practice, and then you're going to tell them that their risk is actually lower. Because the Herald's going to come out with a headline and say, great, you know, New Zealand heart risk has plummeted, gone through the floor. No one's got more than a 15% chance of having a heart attack. Aren't we great? Well, yes and no. Actually more no. But it is going to be harder. So using those numbers is no longer the way I think to drive any of this, okay? So, and let's take that one step further. So at the moment, the way we manage the risk is that if someone's risk of heart disease or stroke is high enough to warrant a discussion about, for example, medication to treat their blood pressure or whatever it might be, then that's informed by, not dictated by, but informed by guidelines that have been set up and adjusted over the years, okay? But overseas, things are changing. Even in the last 5 years, there's been an acceleration of change in what various guidelines across the world are suggesting is a level of risk that above which we should be having those conversations. So if you know your 2013 guideline update off by heart, which of course you do, I shouldn't have even needed to bring that up, then you'll know that 10%, below 10% is a threshold that we think people can have lifestyle modification. Above 10 to 20% is a zone of discussion, and over 20% are those who really are at high risk. Well, the rest of the world has gone further than that. So we are now on the far right there. As you can see, the green bar is the level at which we let people drift up to a level of risk, for example, and above the green into the yellow and red is when we start doing something about it. So you can see that our green bar in New Zealand is twice as high as anybody else's other than Australia. So these other places have moved ahead of us because of things like Cochrane. So everybody might know who Cochrane is, but the Cochrane group looked at the use, in this particular example, the use of cholesterol medication or statins for the primary prevention of heart disease. So preventing heart disease in people who have not already had a heart attack, okay? And they're suggesting in their paper that you could treat down, you could justify treatment, this is giving people medication who've got risks down at 5 or up to 10%. Now that's obviously much lower than we currently do in New Zealand, but that's what Cochrane says, and as you can see, that's what a lot of countries in the world have adopted. They've all brought their threshold at which we start discussing with patients treatment much lower than we have. So this is a conversation that needs to occur in New Zealand. We need to have this conversation about, are we happy to keep this up? Remembering that if I'm now going to change a calculator that lowers everybody's risk, then most of New Zealand is going to fall into the green. So suddenly we're going to not be treating everybody. We're going to be leaving a lot of people who are still at risk, who are still going to go on and have a heart attack. 16 a day are still going to die, and yet we've falsely reassured them, if you will, that everything's okay. So if we change one, do we change the other? It's a good conversation and it's worth having, because we're going to need to make a decision this year, and that's why I said big decisions, because this is fairly big decision sort of stuff, I'm afraid, because it really comes back to population health. How many people, how much is the risk, how much is too much risk, who should we treat, who should we not treat? So lots of questions, but that's really the end of what I kind of wanted to say. But just remember, the risk assessment is only the first sort of a step. So just because we've ticked off that we've done them, how good was the conversation that we had with our patients about that risk assessment? Do people even know they had one? Okay? Because I suspect there's loads of people in New Zealand who've had a risk assessment and they probably don't even know it, you know? And therefore, to me, I don't know that that was very good quality. So the risk assessment program needs to be risk management, and it needs to be about quality, not about necessarily, just doing it for the sake of doing it. It's the right thing to do because heart disease is such a big deal. So it's the right thing to do. We need to assess people to know if we should do something about their risk, but we can't just leave it at, okay, fine, you've had your risk assessment, that's great, off you go. Have a talk to them. Discussions are the key, and that's where I'll leave it. Thank you.